Okay, so today I'm going to talk about the neurological examination of the speech and higher centres. So what we're going to cover is speech, and then we're going to talk about parietal lobe function, temporal lobe function, and frontal lobe function. I'm not going to talk about occipital lobe specifically here because that's assessed elsewhere in cranial nerves. There's three parts to talk about when you examine speech. There's dysphagia, which is a dominant higher centre problem in the use of symbols for communication. There's dysarthria, which is a difficulty with articulation, and there's dysphonia, which is an altered voice quality with reduction in volume. So as you can imagine, that occurs at different levels. The best way to start with examining speech is to get the patient to talk freely, so about where they are, what's going on, just to try and get a sense of what could be a problem. Also need to test comprehension pretty early on, so touch your nose, touch your chin, touch your ear. Yes or no phrases are quite useful, and then repeating phrases such as no ifs, ands or buts, in British Constitution or West Register Street. So those things also can test dysarthria. Naming two objects is useful. If there's no abnormality here, you can move on. If there's something's abnormal, then you need to go into more detail. What you're trying to figure out here is where the dysphagia is coming from. So receptive dysphagia is a problem where you cannot understand spoken words, which is auditory dysphagia, or a written word, which is alexia. This condition is suggested when the patient's unable to understand basically any commands or questions, or can't recognize written words in the absence of deafness or blindness. Speech here is fluent but disorganized. This is in contrast to expressive dysphagia, which is a problem with the back of the frontal lobe in Broca's area. Here the patient can understand but they can't answer appropriately, and speech is non-fluent. So certain types of speech can be retained by this, so things that are automatic, such as word series, days of the week, letters of the alphabet, may come out pretty smoothly. And sometimes emotional speech can be preserved, so if someone's frustrated or angry, they can swear nicely, but they can't use a normal sentence. It's important to remember that unless this lesion that's causing a problem here is very large, there actually may be no reduction in the other higher intellectual functions, memory or judgment, which will make patients very frustrated because people can be mislabeled as psychotic due to disorganized speech. The next topic is nominal dysphagia, and that's basically difficulty in naming. All types of dysphagia often cause a problem with this. There's also a specific type of nominal dysphagia where people can't name particular parts of objects, as in the end of a pen, but other aspects of speech are normal. And people in this situation often use long sentences to overcome the failure to find the correct word, which is called circumlocution. So classically this would occur with a lesion of the posterior dominant temporoparietal area. However, nominal dysphagia is not really a good localizing symptom, and any cause of encephalopathy or intracranial pressure or a space-occupying lesion can do that as well. And nominal dysphagia often occurs in the recovery from a brain lesion. The final thing here is conductive dysphagia, and that's basically thought to be problems in the pathway between Wernicke's area of comprehension and Broca's area of expression. Basically here you get poor repetition but can still follow commands. So in summary from this point of view, if someone's got fluent speech but there's paraphasic errors, so they get similar but the wrong word, think of the nominal, receptive and conductive aphasia, and that, as before, screening with naming objects, repeating statements and following commands. And you can also test this further by getting someone to read and write. If someone is speaking slowly, hesitantly and non-fluently, expressive dysphagia is a more likely problem. Unfortunately, many dysphasias have mixed elements, and large lesions can cause a global dysphagia. And this slide basically is summarising differences between the two here, from fluent speech versus non-fluent speech. So naming objects is very poor with fluent speech. It can also be poor with non-fluent but better than spontaneous. Repetition is useless in someone that has fluent dysphagia. It's possible with great effort in someone with non-fluent dysphagia, and the phrase repetition is poor. Obviously, if someone has a problem with a receptive aphasia, comprehension is going to be very poor. And despite popular belief, in non-fluent speech, comprehension is often mildly impaired. Reading is difficult with fluent aphasia, as you would expect, and for writing, in conductive aphasia, there'll be impaired writing. In receptive, there'll be abnormal content. So moving on from dysphagia now, we talk about dysarthria, which is a problem with articulation. And the problem here can be at a number of levels. So there can be an upper motor neuron problem of cranial nerves. There may be an extrapyramidal problem, such as Parkinson's disease, and there may be cerebellar lesions and problems sort of coordinating things. So something like a phrase like British Constitution is a good way to test for this. So some of the problems that cause dysarthria are things like a pseudobulbar palsy, which is basically when someone is trying to squeeze words from a tight lips. And so they can get an upper motor neuron lesion with spastic dysarthria, paralysis of facial muscles, difficulty chewing and swallowing. So they speak slow and very pseudobulbar palsy difficultly. Bulbar palsy, I've had a lot of trouble finding an example on Wikipedia, but they're classically described as a nasal speech. So bulbar palsy is a problem of the lower of the cranial nerves at a lower motor neuron level. And other things that can cause dysarthria include alcohol problems and cerebellar disease. The thing to think of too is that any problem in the mouth, such as severe ulceration or candida, that causes problem with talking can cause a type of dysarthria that obviously has nothing to do with cranial nerves. And the final thing is dysphonia. So dysphonia is where there's altered sound of the voice, and that's often laryngeal disease or recurrent laryngeal nerve palsy. Moving on to the higher centres now, the cerebral hemispheres, you would test this if someone's disoriented, has dysphagia, or if you expect cognitive decline. And if the patient has receptive aphasia, it's very difficult to perform the testing, obviously, because they can't understand what you're asking them to do. We'd start with parietal lobe function. So parietal lobe has a dominant lobe and a non-dominant. So for right-hand people, that's usually the left-hand side. Problems with this is Gerstmann syndrome, and then there's a mnemonic AALF or AAFL, however you want to remember it. And the problems here include acalculia, so you can test that with simple arithmetic. There's agraphia, which is you get someone to write. There's left-right disorientation, so basically show the left then right hand and touching opposite ears and parts of the body. So can you touch your right ear with your left hand? Can you touch your left shoulder with your right hand? They also can have finger agnosia, so difficulty recognizing which finger is which. And that can also extend to examining the examiner's fingers as well. From a non-dominant side, graphesthesia, which is the ability to recognize numbers or letters drawn on skin, is impaired. And there's also tactile extinction, which is the ability to feel stimulus on each side, but when both sides are done, you can't pick out which side that is. So for example, you may be able to tell the left and right arm, but then if you touch both arms together, they only recognize you're touching the right arm, for example. Other parts of the parietal lobe function are sensory and visual attention, which basically leads on from tactile extinction. 2-point discrimination is a parietal lobe function, and you can test this with a compass point. Dressing and constructional apraxia is a classic non-dominant parietal lobe function. And spatial neglect testing with a clock face is a good way to do this as well for checking parietal lobe function. Moving on to the temporal lobe, this is really tested when you're looking for memory, so short-term and long-term. So you get them to ask your name, address, and 3 objects. So they classically say 3 flowers. You would get them to try and do this immediately, then at 5 minutes. So it's similar to doing part of the mini mental state examination. And then there's long-term things such as when did World War II start, things like that. Patients with severe memory disturbance can confabulate, and that's not necessarily a temporal lobe function. For example, the classic things are Korsakoff, Wernicke-Korsakoff syndrome with alcohol, which is actually due to problems with nerve cells in the thalamus and the mammillary bodies. And that can also occur not just in alcoholics, but people with head injury, tumour, anoxic encephalopathy, and encephalitis. Frontal lobe function can be assessed by looking for primitive reflexes. There's some controversy surrounding how significant they are because they can appear normally in older age, but if you have multiple primitive reflexes, that's usually associated with diffuse cerebral disease involving the frontal lobes more strongly. So some of the things you try is the grasp reflex. So run fingers along the palm and patient will grab them voluntarily on the contralateral side to an affected lesion. There's the palmar mental reflex, which is the ipsilateral mentalis contraction when stroking a thin eminence firmly. The way the palmar mental reflex is described is basically the beginning of a wince to pain, and it can be elicited by pain to other parts of the body as well. It's bilateral in about 50%, Next thing is the pout and snout reflex. That's stroking or tapping a tendon hammer over or above the lips, which causes pouting. You can get a more extreme version of this where people can start sucking, chewing, and swallowing movements as well. Interpreting a proverb is a good test of frontal lobe function, so patients with this will give concrete explanations. Testing for anosmia would also be part of a frontal lobe assessment, and you also test for gait apraxia. So with this, people have unsteadiness in walking, which can be quite bizarre. It looks as if their feet are stuck to the floor, and it can be a strange, bizarre, shuffling gait. The other thing to do is look in fundi, and there's this thing called Foster-Kennedy syndrome, which is very rare, where basically you have optic atrophy on the side of a frontal lobe space occupying lesion, and you get papilledema from compression on the other side. So frontal lobe damage can occur from tumours or surgery, but it also can be part of diffuse diseases such as dementia or HIV, and can cause changes in emotion, memory, judgment, carelessness, and about personal habits and disinhibition. People can alternate between irritability and euphoria, and it's very useful to get a corroborative history for a change in personality. So just putting those 4 parts of the brain together again. So we've got the parietal lobe, which is things such as dysphagia, acalcular, agraphia, left-right disorientation, finger agnosia, being the dominant side, and then other non-dominant sides or non-localizing things such as sensory and visual inattention, construction and dressing apraxia, spatial neglect and inattention, lower quadrant and hemianopia, osteogenesis, and then seizures. Temporal lobe has problems with memory loss, upper quadrant anopia, dysphagia, and seizures. And then problems with the frontal lobe would be personality change, primitive reflexes, anosmia, optic nerve compression, gait apraxia, leg weakness, loss of micturition control, expressive dysphagia, and dysgraphia, and you can get seizures here as well. In the occipital lobe, you can get a homonymous hemianopia, alexia, and seizures, such as flashing light auras. So a summary of that, putting it all together as well, is when you come up to a patient, you could shake their hand, ask them whether they're left or right-handed, start off with asking the patient's name, their current location, the date, so you're checking short-term memory, so temporal lobe function. Then move on to the speech. So speech, you can ask for objects, which checks for nominal dysphagia. Ask them to do a phrase, so you get an idea here if it's an expressive or receptive aphasia. 1 or 2 step commands for comprehension, and also trying to assess from here whether someone's got a primary dysphagia, a dysarthria, or dysphonia. You then move on to the parietal lobe testing. So in the dominant lobe, the AALF. So you're looking for agraphia, alexia, left-right disorientation, and finger agnosia. General things would include sensory or visual inattention, agraphesthesia, astereognosis, and constructional apraxia, such as a clock face. The non-dominant stuff is quite well tested for in dressing apraxia. Moving on to the temporal lobe, so we've already done that a little bit at the start. So memory for short term, checking the 3 flowers, so for example rose, orchid, tulip. Then testing longer term memory such as when did World War II finish or start. And then finally testing the frontal lobe, looking for primitive reflexes such as grasp, pout, palmar mental, proverb, anosmia, gait apraxia, and finally visual fields, looking for any defects. So this has been mainly summarised from the latest version of Talley and O'Connor. Thank you.